there's been some changes, I think, in like vasoactive infusions that we've been using recently, and sort of wanted to give you some insight as to why that maybe why people are choosing different drugs, and give you a chance to ask questions about them. I think one of the biggest changes we've seen is for a lot of us to prefer using epinephrine over dopamine in patients. And as many of you are probably aware, they have very similar actions. They're both what we call catecholamines, and they stimulate the sympathetic nervous system and the receptors on the different end organs, but particularly the heart muscle, and they both have very similar effects. They have slightly different affinities for different receptors in the heart, but for the most part, they both speed up the heart, and they both make the heart squeeze harder. So while there are subtle differences between them in sort of the way that they bind to different receptors and where those receptors are most concentrated, fundamentally, they're both doing the same thing. Now, the reason why epinephrine was sort of avoided is not the best word to use, but for what I'm going to choose in this unit, is because, while it is true that at certain doses, epinephrine has a greater impact on the distal, arteries and the systemic vascular resistance. And so, there was a belief, I think, that people had that you didn't want to give epinephrine, particularly in what would be considered higher doses, because not only then, you're having the beneficial effects of making the heart squeeze better, but you're also increasing the systemic vascular resistance, and particularly for a heart that's just been on bypass, or that's been ischemic, or that's just struggling in general, you don't generally want to raise the systemic vascular resistance too much, because then you're increasing the afterload on the heart, and failing heart, if you just say in a vacuum, to a failing heart, if you increase the systemic vascular resistance too much, that heart can basically stop working. So that was the reason, that impact on the systemic vascular resistance was the reason that many people chose dopamine preferentially over epinephrine. But I'll tell you, number one, that there are several cardiac ICUs in this country, big, well-respected cardiac programs, where you are not allowed to use dopamine in that ICU. Literally, I've seen their data, they do not use dopamine on any of their patients. And so it makes you question, why would anybody say you shouldn't use dopamine? So dopamine has a few undesirable properties. It can depress the thyroid, and so for most kids recovering from cardiac surgery, you prefer good thyroid function or poor thyroid function. It's thought to have some immunosuppressant actions, and so again, in our patient population, particularly for patients who might be on vasoactive infusions long term, that would be a highly undesirable side effect, essentially, of dopamine administration. There's some people, myself included, who believe that any drug like this that you administer for a long period of time will cause the receptors to, what we say, downregulate in the heart muscle, which means it'll sort of take more and more drug to get the same effect, and the heart just becomes less responsive, not only to the catecholamines that we give the child, but also to the catecholamines that you make, that any person makes just endogenously. And so, particularly for kids who might be on vasoactive infusions for a long time, if there is more of an effect of that receptor downregulation from dopamine than other catecholamines, then you might be concerned about using that versus another. So then there's this other question about, what is really high-dose epinephrine? And in this unit, most people have been concerned about using doses above 0.1. but almost any pharmacology or critical care textbook that you read will say you don't really get any significant impact on the systemic vascular resistance below doses of about 0.2. Now, you know, the thing with any of these drugs is that, like, kids, they have very individualized responses to them. So the same drug in patient A is, you know, the same dose can have a different physiologic effect than it does in patient B or patient C or patient whatever, triple Z. So, you know, you can't make blanket statements and say, well, until I get above 0.2 of epinephrine, you know, I won't see any major effect on the systemic vascular resistance. And you can definitely see kids who are on more moderate doses of epinephrine and they have very clamped distal vasculature. And, you know, that's complicated in the interpretation by what else is going on with them. If they're on higher doses of drugs, maybe they're clamped because they're really sick, you know, and it's not the drug itself. But, you know, it's just suffice to say the same dose of drug doesn't have the same effect on their kids. But the point is that at the doses that we typically use in patients, epinephrine really shouldn't have much of an impact on the systemic vascular resistance at all. And so in that way, epinephrine and dopamine are really equivalent drugs at the doses that we are using. And so then from my perspective, and I think this is what is beginning to be you know, adopted by others, is that there's really no point, you know, to giving dopamine, which has known side effects that we would not want for the child, particularly if it's going to be used at all long term. And by long term, I mean more than a few days, over epinephrine. So, you know, if that's the case, why not just put people on epinephrine, you know, by itself? And so that's what, you know, that's what I do, that's what many people are starting to do, but that's the reason why, okay? Now, that being said, you know, you can observe differences. I mean, one drug may be more or less what we call chronotropic in kids, right? You know, epinephrine in one kid might speed their heart rate much more than dopamine does. And so every child is still a little bit of a, you know, sort of experiment. And if if I start a kid on epinephrine and that kid goes crazy tachycardic, I might try, if I still think that a catecholamine is the best drug for him, put him on dopamine and see what his chronotropic response to that drug is. But, you know, but absent those type of effects, for me, I just think epinephrine is superior in every way, you know, by being essentially equivalent or maybe even a bit better in terms of its inotropic effect and not having the side effect that we talked about. So, questions about that?
So the long-term epi doesn't have the same effects on the receptors that the dopa does?
I mean, it does. You know, and in the adult heart failure literature, there's some reports of hospitals that rotate their inotropic medications. You know, so every couple of weeks for adults who are chronic heart failure and maybe waiting a transplant or whatnot, who are chronic catecholamine infusions, they will, you know, have a policy of protocol of rotating to a different drug, you know, to just keep targeting slightly different receptors. I mean, even a drug like norepinephrine, which has primarily an effect on what we call alpha receptors on the you know, distal arteries. I mean, that has myocardial effects too. There are alpha receptors that cause that impact contractility on the myocardium. And so, you know, some folks have talked about rotating them. It's not really a practice in either pediatric heart failure or, you know, in the more acute post-operative, say, patient. But epinephrine will have the same impact long-term as dopamine will in terms of down-regulating the receptors. But I think less, I mean, certainly not the effects on the thyroid or the immune suppressive effects. So is that something people have noticed? I mean, particularly people who've been here a while, using a lot more epinephrine alone rather than, you know, sort of, I mean, before it used to be you added that to dopamine, you know, the alone dopamine was always used. And, you know, in the patient who's, let's say, 3-year-old at sub-AS resection, and they come back from the OR, they're extubated, they get a little hypotensive overnight, you could probably give them any drug in our armamentarium to raise their blood pressure. It would raise their blood pressure, and they'd be totally fine the next day. And you know, it wouldn't matter. You could give dopamine, epinephrine. They probably don't need either of them. They probably just need something to raise their systemic vascular resistance a little bit. I'm assuming their function is okay, as most of them are. You would be probably better off just giving a little more epinephrine or vasopressin. But it doesn't matter. You can give them any one of those 4 drugs, they'd be totally fine by the morning, you know, off it and ready to go. And all these effects, you know, that I'm talking about are irrelevant in that patient. So, you know, if I walk into a room with a patient like that and they're on dopamine, I'm not going to say, stop the dopamine, put them on epinephrine, you know. I may roll my eyes, but, you know, the thing is that, you know, it just doesn't matter. Whatever it does matter, I think, is that the kids, you know, more complex surgery, more likely to be on vasoactives for at least 2 to 3 days, and, you know, and or more likely to have significant myocardial dysfunction. In those kids, I mean, would really, my preference, again, with others as well, is that we would probably be using epinephrine for our children.
So we used to go like dopamine up to 10, and then we would start epi.
Mm-hmm.
So is there kind of a threshold of epi that we would go up to before we would start something else with it?
Well, I mean, that's always a complicated discussion, because it always depends what you really think the underlying problem is.
Mm-hmm.
Personally, you know, I don't, if I'm giving a kid epinephrine and I'm escalating that, and that's not holding the kid's blood pressure, and once you start getting above 0.1 of epinephrine, you really got to start to wonder, like, is there something going on here that I just can't support this kid with this much drug? There are some people who say around the country, very experienced, very, like, people whose opinion is very well respected in pediatric critical care medicine, who say, if you have to support a kid with more than 0.1 epinephrine, like, you should probably be on ECMO. Now, I don't necessarily agree with that, because I think there's a heck of a lot more risk of, you know, supporting a kid on ECMO than 0.1 epinephrine. I think their point they're trying to make is that in their experience and at their institution, where maybe they use lower doses of vasoactives for whatever reason, and I'll just say, we tend to use a lot higher doses of vasoactives for whatever reason than most other, not most other, but many other institutions. And I don't know why that is. There's probably 10 or 20 different reasons why that might be. I don't know which one of them or how many of them contribute, but I think what they're saying is that when you start to get above the level of vasoactive support that is typical for a patient, it's like what we always say, if you see someone who's not acting like the normal patient, they figure out there's something wrong. They have a residual lesion, their function isn't as good as maybe you thought it was when they first came out of the operating room, what have you. It's like, figure out why they're not acting the way you expect. And so so to your point, like, if I'm going above 0.1 epinephrine, then, you know, it may be worthwhile to consider that it's not just like that the patient needs inotropic support. Maybe they do need a little bit more support for their systemic vascular resistance. Maybe that systemic vascular resistance is a bit low, and so you know, that would be where you might try a pressor, you know, pure pressor agent like norepinephrine or vasopressin or something. You know, now you might get that effect by just cranking up the epi a little bit more, because as I said before, once you start to get up to, you know, like 0.2 of epi, like, then you do start getting some significant pressor activity, but that comes with the downside of, you know, more chronotropy, possibly tachycardia, you know, certainly epinephrine increases overall metabolic demand, so you're increasing the kid's oxygen consumption. That makes it, you know, worse in terms of, you know, relative oxygen delivery and everything. So there are downsides just cranking up the epinephrine. So, you know, for me, once you get about 0.1 epinephrine, you know, I'm starting to say, this is now a relatively generous dose, and let's make sure we know what the problem is here, and let's start thinking about another agent for them. It is not, what I do not think, well, I should add dopamine for this patient, because that is adding a second drug that's doing exactly the same thing as epinephrine. And so if I thought the kid needed more inotropic support, I would just give him more epinephrine. Now, there is also something that, you know, I think a phenomenon that we see related to epinephrine, where you got the kid who's struggling, maybe is on a epinephrine drip at like 0.1 or so, and then we start giving epi spritzers. And just as an aside, I will say that, giving epi spritzers is not a sustainable therapy, okay? Like, when we're doing that, we should either be thinking about going on ECMO or doing something else, like opening the chest or going back to the OR or something like that. Like, it's never okay to be giving multiple epi spritzers without, like, a plan B and C coming up. But you often see a kid who is on an epi drip, let's say at 0.1, and getting epi spritzers, and they really respond to the epi spritzer. And their blood pressure comes way up, and people are like, well, why are they responding to epi spritzer, but they're on this high dose epinephrine? And in some of those cases, I think it's what we talked about before, they're getting a bolus of epinephrine at a dose that really does cause a very significant increase in their systemic vascular resistance. So that is good enough to bring up their blood pressure a lot. But when that wears off and then they're back at their steady state level that's from just the drip, then that's not enough to dramatically impact their systemic vascular resistance. And maybe that's what that kid needs to increase their blood pressure. So I think that's, something when I see a kid who's like really responsive to epi spritzers, but who's not like sort of normal tensive on epi infusion at that rate, I think, well, maybe this kid really needs more pressor activity, and that's where I think about maybe starting something like norepinephrine or vasopressin.
So is this why we're seeing norepi use more then? I feel like we hadn't seen a lot of that in the past.
Yeah.
It was more of a vaso or
Yeah.
dopa and epi.
Well, I'm also probably responsible for that because I was the one who started using a lot of norepinephrine. And the reason I started using norepinephrine over vasopressin is because, I feel like there's just a way more, that's what I'm looking for. I can anticipate the dose response a lot better from norepinephrine than I can from vasopressin. Like, I see a lot of kids who, like, there's some kids who respond to, like, 0.0003 of vasopressin, which, by the way, is, like, that's not even, like, physiologic replacement for a kid. That is essentially homeopathy, so I'm not ever sure why they do respond to that, except that vasopressin can potentiate the impact of catecholamines. So if you have a patient who's already being maintained on a dopamine drip or an epinephrine drip, you give them vasopressin, even without any direct effect on the systemic vascular resistance, which is what we typically think we're giving that drug for, it actually potentiates the myocardium to catecholamines. And so I do wonder if kids who respond to these very low doses of vasopressin are really just responding, essentially having an increased effective dose of their catecholamine. But, I see some kids who respond to these very low doses and some who don't respond to, any dose of vasopressin, whereas norepinephrine, I sort of better understand, me personally, I better understand, like, if they're not responding to this, then, maybe they'll respond to this. If they're not responding to this, then, like, we're in real trouble here, whereas it's just, so it's more predictable to me than vasopressin. Norepinephrine's a good drug. I don't know why it has, like, a bad rap. It does probably have some chronotropic effect, so if you're really trying to stay away from that, like maybe in a patient with jet or something, I'd pull vasopressin before I, chose norepinephrine. But in almost any other patient, I'd choose norepinephrine. It's just more reliable to me. And it does have some myocardial contractility effect, just in the way that vasopressin does as well. So that's why I personally like it, and people just started using it, I think, because we weren't told anymore to be afraid of it. In the adult ICU, this was really eye-opening for me when I was over there. Like, we get these 80-year-old grandmas coming out of the operating room after having their cabbage surgery. They got low ejection fraction, and they just had their 3-vessel cabbage, and like the standard drugs for them are milrinone and norepinephrine. That's what they come out on, And so, like, if it's good enough for them, like, why wouldn't it be good enough for our patients' hearts are generally healthier and better contractility and whatnot? So, it's not a drug I think we should be worried about using too much. Other questions about that? How are we doing on time?